Hello, my name is Dr. Syed Raza, and I work as a cardiologist in Bahrain. And today I'm going to speak on a very important topic, and I'm going to discuss a not a very well known molecule, which is lipoprotein little a, and the associated residual or hidden cardiovascular risks. Now, before I move forward, I would like to put this question on the screen. Which of the following statements is correct? Lipoprotein little a and apolipoprotein A are similar in structure and function, or 1 in 5 individuals have high lipoprotein little a or LP little a. Till date, there is no therapy for lowering lipoprotein little a. Apoprotein B carries cholesterol from peripheral vessels to the liver, or it is E, high ApoB/ApoA ratio is desirable. So you can think of an answer, and obviously I'll probably give you the answer at the end of the talk. But if not, then obviously this is just to stimulate your brain a little bit before I move on to the main topic. So in the next 15 to 20 minutes, I'm going to talk about as to what is lipoprotein little a, what are the associated cardiovascular risks, and what are the therapeutic options, if at all, that are currently available to treat or manage LP little a. Now, the question is, what is lipoprotein little a? Now, just to let you know that there are still many physicians and also some cardiologists and of course some general practitioners who have absolutely no clue as to what this molecule is all about. So lipoprotein little a is a type of lipoprotein which is mainly comprised of LDL-like particle, and then there is a second molecule which is a complex lipoprotein which is called apolipoprotein little a or ApoA, that is coiled around the LDL level. Now this is not something new. This was discovered many years ago in 1963 by a German physician called Cardiology. But it has only recently come to light that this poses a significant risk for future cardiovascular events and also increases the cardiovascular deaths. So this is what I was talking about. So there is a LDL-like lipid core, and then around that, these are the cord-like structures, which is called ApoA, and this is a highly variant lipoprotein. And if you look at the next screen, so the ApoA, which is attached to the LDL molecule, it has also got ApoV, which is again another lipoprotein, and everything together once it attaches with the plasminogen, and as you know, plasminogen again is a thrombotic factor, and once it attaches with the fibrin, then a clot or the atherogenic clot is formed, and that can lead to future coronary artery disease or cerebrovascular disease. Now, LDL core increases atherogenesis. We all know for a very long time that the presence of LDL molecule in itself increases the risk of heart attacks and stroke. And the ApoA also increases the thrombogenesis, which is again a part of the molecule, and it has got the oxidized phospholipids that increases the vascular endothelial damage and also causes inflammation. So therefore, the presence of LP little a or lipoprotein little a increases the risk of cardiovascular disease at least 4 times, some say even 6 times, compared to that increased by LDL molecule, which we all know about very well. Now, there are two types of LP little a. There is a large Lp(a) and there is a small Lp(a). And the ones which are small, they have got the smaller the isoforms, and they are supposed to be more atherogenic and they are more deadlier in causing future cardiovascular event compared to the larger molecule which have got the higher molecular weight. Lp(a) is genetically determined and it is found on Lp(a) gene and on the reverse strand of chromosome 6q27. So if somebody is carrying this gene, then obviously there is a chance that 50% of the children will inherit the gene and will have high Lp(a). The question is how common the lipoprotein A or Lp(a) is. At least 1 in 5 individuals worldwide, they have got high levels of Lp(a). And the majority of these individuals actually may not be aware that they are carrying this gene or carrying this molecule. And definitely these are the hidden risks or the residual risk in the individuals. Unless they are not investigated and looked for, then obviously they continue with this risk and they are likely to suffer the unfortunate event, heart attack or stroke, somewhere down in their lifetime. So it is a very common molecule, very commonly present, although it's not investigated or looked for. But as the figures say, or that you see here, 1 in 5 individuals worldwide, which means that 1.5 billion individuals all across the globe, they are carrying this gene and they are suffering or have high levels of Lp(a) compared to the familial hypercholesterolemia, which are present only in about 25 million people worldwide. And it differs from uh, there's a variation in the ethnicity, so there's a lot of genetic variations across different ethnic groups as to what the level of Lp(a) is in these different population of different ethnic backgrounds. Lp(a), as I said, is more deadlier than LDL. It increases the risk of myocardial infarction by 3 to 4 times. It also increases the risk of cardiovascular mortality by 1.5 times and all-cause mortality by 1.2 times. But at the same time, it also increases the risk of stroke. It also increases the risk of aortic stenosis and peripheral arterial disease. And once the level starts to rise, the risk of future cardiovascular event certainly rises. And the significance is once the Lp(a) is more than 50 milligram of per deciliter, then certainly your rise in the future cardiovascular risk is much higher, and there's an increase 31% more risk of heart attacks and strokes in these individuals. Now we do assess the patient and we risk stratify them for the future cardiovascular event. We use different scores, and once we have used this scores, then we classify these patients into low, intermediate, and high risk for future cardiovascular event and also cardiovascular death. But when we put the equation into the equation, the measurement of Lp(a), and if this is higher, then certainly it changes or reclassifies this group of individuals for primary prevention as well as for secondary prevention. The risk sometimes is definitely, depending on the level of the Lp(a), increases considerably with the addition of this into the equation. Now, whom should we measure the Lp(a)? Now, different guidelines, they have got a different suggestions as to which population we should be measuring the Lp(a). Now, it is the European Society of Cardiology and European Atherogenic Society and also Chinese Medical Society promote that the Lp(a) should be measured once in person's lifetime, and the age that is recommended is anybody above the age of 5 should have their Lp(a) checked. Whereas the other societies, the international societies, provide guidelines in patients who have got a family history of premature coronary artery disease or cerebrovascular disease, and also if they have got a personal history of premature cardiovascular disease. And there are some societies which will which support checking of Lp(a) if they've got a moderate to high risk of atherosclerotic cardiovascular disease, or there is a refractory elevation of LDL levels. So if the LDL levels are high and you give the traditional treatment, and if the LDL level does not respond to come back, then you may suspect that there may be a role of Lp(a), and then according to some guidelines, you may check for Lp(a) as well. So Lp(a) again is a blood test and not a very complex lab investigations. You do not need to fast for Lp(a), and once you've got the Lp(a), then that's it. You do not need to repeat. So you do not need to monitor the level, because at the moment there's nothing that can change the Lp(a) levels. No exercise or the diet is going to help you reduce your Lp(a). Having said that, it is again important to emphasize that yes, the lifestyle changes do not affect its level, but certainly these are important to take care of the other risk factors that the person may be having. So normal cutoff, as I said, is the 50 milligram per deciliter. And if you're interested in nanomillimole, then the cutoff is 125 nanomillimole. And anything above that, the risk of future cardiovascular event, including cardiovascular death, increases considerably. Now, the question is, since I mentioned that there is no treatment, even the lifestyle changes, the statins do not bring it down. The PCSK9 inhibitors, they have a very small role to play in getting the levels down of Lp(a). But how about aspirin? Now, the answer comes from the ASPRI trial, which studies more than 12,000 patients. And it was found that the patients who were carriers of Lp(a), and if you provided them with aspirin, daily small dose of aspirin, this reduced the risk of MACE by 56 to 76%. And also if the Lp(a) levels were more than 50 milligram per deciliter, so which means that the patients are actually having higher levels of Lp(a) in their bloodstream, and giving aspirin to them also reduced the risk of cardiovascular disease by at least 50%. Now, this is again another study which was published very recently, and it was shown that the cardiovascular risk reduction for primary prevention, if aspirin was used and it was compared to placebo, where patients one arm took aspirin, the other arm did not take aspirin, and the patients who had high levels of Lp(a) and who were on aspirin certainly did better, and there was a 46% relative risk reduction of cardiac events in patients who were taking aspirin compared to who did not take aspirin. Now, till now, what do we have to treat Lp(a)? Now, we have medications for lowering the LDL cholesterol. We have got statin as a TMI. We have got PCSK9, and we have medicines for high triglyceride, high blood pressure, and so on and so forth. But unfortunately, till date, there's no FDA-approved medication that is in use in clinical practice for lowering the Lp(a). But the therapeutic options are there, and some of the therapeutic options, particularly the RNA targeting therapies, which are the antisense oligonucleotides and short interfering RNAs, they are still under research, and quite a few trials are currently in progress, and we are hopeful that they will be available for our use in clinical practice. And the initial phase 1 and phase 2 trials are quite promising, and they have shown that they do decrease the levels of Lp(a) by at least 90%. And one of the modalities of management is the lipoprotein apheresis, and this may be advocated in individuals who have got a very high risk of premature coronary artery disease, or there's a very, very strong family history of premature coronary artery disease, and they do carry this Lp(a) is very high, then lipoprotein apheresis may come handy. PCSK9 inhibitor, as I mentioned, has got a small role, in reducing the Lp little a. Statins do not affect much in reducing Lp little a, but statins, where it is required to lower the LDL and also reduce the overall cardiovascular risk, then certainly statins should be continued in these patients. So these are some of the antisense oligonucleotide and short interfering RNA therapies that are in the pipeline, and they are. This is a little old slide, but there are majority of them are now in phase 2 trials. Some of them have entered phase 3 trials, and I'm hoping that in the coming years we will have some good news in terms of treatment or therapies that will be available to lower this molecule Lp little a and reduce the burden of cardiovascular disease and cardiovascular death. Lepodisiran, again, this is in a phase 3 trial at the moment. This is a short interfering RNA therapy, and the results so far from the phase 1 and phase 2, they are quite promising. Pelacarsen has been studied, and it is still under trial. And it has been shown that the pelacarsen, when given to the patients with high Lp little a, pelacarsen can bring down the Lp little a as high as 67%. Oral molalapin. Now, all the medications under the trial for reducing Lp little a, they are injectable, but you'll be pleased to know that we are also expecting an oral medication for reducing Lp little a, which I think is a great breakthrough, and I'm hoping that in the next coming years this will be available, and it will be very handy for the patients who would like to avoid the needles and would like to take it in the tablet form or oral form. So oral molalapin for lowering Lp little a. Now it is still in the trial, and it has not received any FDA approval for its clinical use yet. And this is a small trial, which is the Kraken clinical trial, and this has shown that Lp little a is significantly reduced with molalapin compared to placebo. So what is the consensus from the European Atherosclerotic Society? Now, European Society of Cardiology and European Atherosclerotic Society does recommend that the Lp little a should be checked at least once in adults, once in a lifetime. And Lp little a interpretation should be in the context of the absolute global cardiovascular disease risk. And if they have got Lp little a, then obviously all the risk factors, they have got to be managed extensively and intensively. And we should make sure that these are modified with other medications that are available. And specific Lp little a therapies, since we do not have them, but once they are out, then certainly this will come in use as well. So ladies and gentlemen, finally to conclude, Lp little a has a high prevalence, but often not tested. So I would like to pass on this message that please test Lp little a in individuals, particularly who have had a heart attack or stroke prematurely, say in their 40s or 30s, or if there is this very strong family history of premature cardiovascular disease. Lipoprotein little a is more important predictor of future cardiovascular disease risk compared to LDL particle, and there are now clear indications for testing. As I said, that there are certain guidelines where all individuals at least once in their lifetime should be tested, and treatment options are still limited, but we know, and I've discussed, that there are few trials that are underway, and we are very hopeful that in the coming few years we'll have some solid treatment to take care of Lp little a and therefore reduce the overall burden and risk of future cardiovascular events and including cardiovascular death. With that, I thank you very much for your listening.